Hi there. Welcome to the While You Wait podcast, where it's all about helping women just like you learn about the bladder while you're waiting for your appointment with that specialist. Each week, I'll combine science, medicine, and common sense so you can learn, become empowered, and get started on your journey to dryness. I'm your host, Dr. Sarah Boyles, a board-certified urogynecologist. Let's get started. Hi there. I'm so very excited to bring this episode to you. I've done lots of interviews for this podcast, but this may be the first time that I've felt starstruck. You all know that my clinical career focuses on urogynecology and the pelvic floor. And in this clinical domain, there are some superstars who have made it their life's work to figure out how to prevent and treat pelvic floor disorders. As a practicing clinician, their work helps guide my clinical practice. There are lots of people with opinions on how to treat the pelvic floor. You see that every day. But it is much rarer to find people who are doing the hard work, who are doing the research, and really studying what works. My guest today is one such superstar. Her name is Chantale Dumoulin. She is French-Canadian, and she is a professor at the School of Rehabilitation at the University of Montreal, where she developed and currently directs the graduate perineal and pelvic rehabilitation program for physical therapists. This is the only program of its kind in Canada. Professor Dumoulin is interested in the pelvic health of older women. Her research aims to better understand pelvic floor muscle dysfunction and improve the prevention and treatment, as well as to identify women most likely to benefit from conservative therapies, such as pelvic floor muscle rehabilitation. Her methodologic expertise includes the development and psychometric evaluation of measurement tools, the evaluation of the effectiveness of prevention or curative treatments through randomized controlled trials and other studies, as well as writing systematic reviews. Let's go ahead and let's get started with the interview. I want to thank you so much for being here. I am a huge fan of your work, and I just kind of want to summarize what you do. You're a physical therapist in Canada by training, but you do a lot of research, and your focus is really on the female pelvic floor, how to age gracefully, and proving what treatments really work to help prevent and treat incontinence in women. Is that fair?
Yeah, and maybe we can add to that since I started research, I've been doing a lot of studies on what are the dysfunction of the pelvic floor in younger women, but also in older women, in order to do individualized medicine, if you want to get the best treatment for a certain population. And what is good for younger women after delivery might not be good for older women, 60 or 70 years old, who have incontinence. So there's different things we're going to be working in terms of pelvic floor with different ages.
That's so exciting. So I think there's a lot of not so great information out there on social media, and I'm going to take what you said and I'm just going to use that as a segue. One of the things that I see a lot on social media is physical therapists out there posting that Kegels don't work.
Mm-hmm.
And can you comment on that? What do you think about that? Is that true?
I think it's unfortunate that we can find this out there, and I see it too. And I think that if we go back to the study of Kegel in 1958, if you read about what was the program at that time, it was to do 500 pelvic floor muscle contraction in a day. So 5 squeeze and rest. So obviously nobody wants to do that today. And we have moved forward with the training theories. And obviously, Kegel are not the best to go, but in a way, if you're going to be talking about it and talking about those 500 rapid contraction, maybe it's not the best way, but pelvic floor muscle training is the way to improve the function of the pelvic floor. And now we know that there is dysfunction in terms of the strength of the pelvic floor, in terms of the endurance of the pelvic floor, in terms of the rapidity, the coordination. So we have to aim to train those function by giving the patient a exercise program that will train these. So we need to give strengthening exercise, coordination, rapid contraction. So it is effectively not Kegel. It is Kegel plus, I would say. But I disagree with the fact that we should move completely away from pelvic floor muscle training and go with breathing, go with other techniques or approaches where there has not been any evidence, because there are evidence for pelvic floor muscle training, but maybe not those 500 rapid contraction. Maybe we have better than that now.
Yeah. Yeah. So you just think that might be just too simplistic, right? To say not to do that. And I think maybe some of that is the fault of the physician, right? Because I think physicians are notorious for sending patients away and saying, okay, teaching patients how to do a Kegel, or maybe not teaching them how to do that, but sending them away and saying, okay, do 30 a day. And then we'll kind of see how you do. This is going in a slightly different direction than I planned, but, what would you say to the physician when we're sending patients away in terms of what should we be telling them? Can patients do these things on their own?
First of all, the physician should, during their evaluation, evaluate the pelvic floor, just see if the women can contract or not. If the women cannot contract properly, if the woman doesn't really know where the pelvic floor is or how to solicitate the muscle, then I don't think it's worth giving the patient an exercise program right away and tell them to do it on their own. Studies have shown that if you tell patient to follow a sheet of paper with Kegel or any pelvic floor exercise program, 40% of them will not do the right contraction. They might contract their abdominals or buttocks. They might do a Valsalva, which the reverse of a pelvic floor that you don't want to do. So I would say if you have physiotherapists in your area, and I don't know if in the States it's privately mostly, so there might not be as accessible as in Canada and other countries. But if you see that the woman cannot contract well, it's important that they see a physiotherapist so that they can at least understand the movement, and then they can go on different approaches, the either one-on-one treatment or group training, or that would be less costly.
Yeah. So I'm in Oregon and we have great physical therapists here, but some patients don't want to go to the physical therapist, right? Either because they just don't like that idea, or, maybe they don't have the time or expense. I mean, there are lots of reasons why patients don't want to go. But you've done some work on group classes and looking at group classes, and you've found that women do well with group classes, correct?
Yes. So I would say, just to bounce back on what you
Yeah.
said, if women don't want to see the physiotherapist because they don't want to exercise, I think there's no way around it. If we want the pelvic floor to get stronger, to be more functional, you have to train the pelvic floor. So eventually, if the idea of seeing a therapist to do the training is not, you don't want to do it, well, it won't work. Right now, the evidence are not strong for any other approach like yoga, like Pilates, like the even magnetic chairs. Or so the first line treatment is to train. And this is the same way as training other muscles. So I think, but there's different ways of doing it. Like you say, if you have less money, there's the possibility to do it in group. There's also the possibility to do it online, and there's like tele-rehab, and there's also the possibility to do it with mobile application. So if we come to the group training, we have done research comparing individual training to group training in postmenopausal women, in menopausal women. And we found that the group training was non-inferior, meaning that we had the same results as if you were doing the one-on-one intervention. So obviously, this is quite exciting because you get the same effect, but also it's less costly for the patient, but also for either the private clinic or the governmental agencies that pay for that. So this is nice. In addition to that, we found that women who were in a group, it was helping them to be adherent to their exercise more than if they were in individually with the physiotherapist. So there's that solidarity with the others that have the same problem, that help women be more adherent to their exercise, to come more to their intervention. So I think this is something that is new and that's very exciting for incontinence treatment.
So I'm going to get back to that because I think that is really exciting. And I think as a practitioner, it is exactly the opposite of what I would have expected or a lot of assumptions that I have made over my career. But when you talk about group therapy, one of the things that you did in your trial was you gave everybody one individual session, correct? To make sure that they knew how to do the contractions. And even though they were in a group, they had access to a physical therapist if they had individual or personalized needs, correct?
Exactly. And I think it comes back to what we were saying at the beginning, the importance of knowing how to contract the pelvic floor because this is a hidden muscle.
Yeah.
If you contract your bicep, you know that you're doing it right. But if you're contracting your pelvic floor and it's weak or haven't been doing those exercise in your life, you're not really sure if you're doing the right thing. So all the women in the trial had one session with a physiotherapist to make sure they knew how to contract and that they were able to repeat that contraction so that they could move to a group. The women who are not aware of their pelvic floor, I would not send them to a group. I don't
Yeah.
think it would work. Mm.
Yeah. Yeah. I think that's important. And I also think, what you said about being willing to do the exercises is important, right? Some people are not willing to do it. And then, sending them to physical therapy is a little bit of a waste of everybody's time, right? Because you have to believe and be willing to spend the time and engage. So you said that in group therapy, women did better. They adhered, well, maybe not did better,
We
but
did the same.
they
Yeah,
did the same, but they adhered to their exercises and that there were a lot of social benefits of being in the group. And I would tell you that I've always assumed that women don't want to be in a group with these things. They don't want to talk about it, but you kind of found the opposite. Were you surprised?
I was surprised because the women, when they were randomized in that trial, they knew there was two treatment and they were randomized to one of the two groups. They didn't know what was the other group. So I was afraid that the women who would be in the group training, because it was not usual in Canada at that time, I thought that maybe they would refuse to participate, but no one refused to participate. So it was surprising, but surprisingly good. Additionally to that, what I can say is that we did some qualitative analysis. So we interviewed those women after the treatment, and we're just publishing now in the Journal of Physical Therapy of Canada the results. And what we found was that the women who were in a group perceived their intervention not as a treatment so much, but as an exercise group that they were doing with others. So, because of that, after the intervention, they were more keen to continue doing those exercise as a way of life than
Yeah.
the ones that were in the treatment who might have thought that they needed the physiotherapist to do a treatment. Rather, it was an exercise class for
Yeah.
the other. Do you see the difference between the two?
No, I definitely see the difference. And I would tell you that when I send my patients to physical therapy, right, the physical therapists all have very different environments. And there is a physical therapy group in town that really specializes in athletes. And when patients go there, they feel like they're rehabbing next to an athlete. And so there are a lot of very positive social things that happen there versus when they're rehabbing next to somebody who, perhaps had a stroke and it feels like they're sick. It's a very different, mindset. And I think, sometimes we medicalize things and that's not what people want. I mean, I think that's why there's this big push to do things online because it feels like you're working on yourself and you're doing positive things rather than being sick or treating something.
Exactly. I would add also the fact that a lot of those women, they were not talking about their incontinence to anyone. The added benefit of the group, I think, is to be able to see in the same room that you're not alone. There's other women who have the same problem. Also, some of them said, I felt dirty, I felt old, and just to see other women in the room
Hmm.
that or beautiful
Yep.
or not so old, they don't smell bad. You're kind of encouraged to take part of this exercise group and take care of yourself because you see other and you support also each other in
Right.
that. We're doing right now the 8-year follow-up of this study. I don't have the result. We're going to be presenting at the ICS, but what I can say is that we were very surprised to see that 70% of the women who did the trial 8 years ago, we were able to find them and they agreed to participate. So all of them that we were able to find because we had the good phone number and they didn't have moved, we were able to recruit. So it's going to be interesting. And a lot of them showed our student that they still had their booklets of exercise and
Yeah.
they shared it with their sister-in-law and with their friends. So like I said, I think it's a way of life and exercise that they want to keep on and share.
I think that's amazing. And that really speaks to what, amazing work this is because you don't find people after 8 years after a trial, right? I mean,
Mhm,
usually
mhm.
they're kind of long gone and doing other work and it's just not as important to them anymore. So, it just shows that you've really made a meaningful difference in their lives, right? That they're willing to participate again. So, I've also heard people say that you cannot improve your pelvic floor after menopause with strengthening.
Mm.
What would you say to that?
I think it's always time to improve your pelvic floor. And we had in our studies women that were 80 years old when they started 8 years ago. And actually, what's interesting is that it's probably less difficult to improve or to give a women what they need in terms of added strength when they're older because their need is a little bit lower than younger women. So if I give you the example, postnatally, because there were maybe trauma during the delivery, the pelvic floor weakens. And if the woman has urinary incontinence and wants to go back to running and jumping and doing all those things, we will need to work with her to increase the function of her pelvic floor enough so that she can do those activities. And in older women, it might not be running and jumping because when she's 80, she's not doing that, but it's just walking around the house, doing her gardening, going to the store. So the added function or strength that she needs is lower. So I would say that it's possible, and that's what we saw. It's possible at any age. The only thing you need to do is to do the exercise to use the training theory actually, and to give an exercise that is difficult enough to build muscle mass and to build function.
Yeah. And so would you say that you believe everybody should be formally evaluated before they do anything on their own?
Yes, I think so. Because, like I said before, the chance of doing the wrong thing is high. It's 40%. And if you're going to be pushing downward rather than contracting your pelvic floor because you don't understand how to do it, it's not worth. And I think that a lot of women that say it's not working, it might be related to the fact that they're not doing the right exercise or they're not doing it with the right exercise program or progression, because
Yeah.
this is also something that is important. You need to exercise, but with time, you need to progress, make those exercise more difficult. And in the program we did for aging women in group, it was a 3 months program. And every month it was incremental. So every month we were increasing the number of seconds, the number of repetition. We were making those exercises more difficult
Yeah.
for the women.
And I think that's something that's so difficult for most of us, or maybe just for me, to do on your own, right? I mean, I need someone to be saying to me, "Okay, you've mastered this, right? You need to be making it harder and not just running through this as quickly as you can." When you did your groups, does it matter who's in the group? I mean, were you careful to make sure that women of the same age were in the group, or because I think younger women sometimes get a little discouraged if they're only with older women.
Exactly. So in the group training that we did, comparing to the individual training, it was women 55 and up. So we were trying to keep them in the same age category, plus or minus 10 years old.
Okay.
So around 10 years old difference. So obviously at 55 to 65, a lot of them were still working. So they were more available in the evening. So we had those younger class in the evening, and we had the older women that would want to come more in the morning or just after lunch. And so we took care of that because we wanted them to be more in line with,
Yeah.
their question and their speed. We did another study in which we had women 18 and over. And again, we did the same thing. And like I said, the progression of exercise was a little bit more rapid in younger women than in older women. And the topics also in every what we're doing is for an hour session, we also do education at the beginning. So, education about the pelvic floor, education about incontinence. And if it's younger women, we will be talking about topics that are different than in older women, in which we will talk more about menopause, in which we will talk about prolapse and things like that.
So I have a question for you. What would your advice be for kind of a typical mid-40s woman who has maybe a little incontinence, right? Avoids trampolines, nothing excessive, but is looking to have her pelvic floor age as gracefully as possible? I mean, what prevention would you suggest?
Yeah, I think this is important to know that although it's just a little bit of leakage, it will not get better on its own. And that's really the best time to start taking care of it, because you're not going to have to do that much training because you're kind of on the line of dysfunction of the pelvic floor. So I would tell her to, first of all, see a physiotherapist to evaluate the pelvic floor dysfunction, and then either go on to that physiotherapist for training or join a group, or maybe also there are some session online, but at least, or use an application, but at least do the assessment first, then do the program that will be more in line with your way of life, so that we know that you're going to be doing it completely, that you're going to be able to adhere to it. And I think that if you have leakage, it's important to do active rehabilitation for at least 3 months. And this is the training theories that tells us that you need to build muscle mass and it will take time. So at least 3 months. And then you need to do maintenance. So then you need to know that you have a certain weakness there. You might not be incontinent anymore. So you need to keep those muscle active at least once a week. That's what we saw in our study that was needed, at least once a week. And you also have to be careful of what you're doing. If you're going to be, if you're constipated and you're pushing a lot when you go to the toilet, you have to try to take care of that to reduce that pressure. If you're doing an exercise that is putting pressure, if you're doing trampoline again, or if you're playing tennis, it's okay. We want you to be active. But at the same time, you need to compensate by maybe doing a little bit more of exercise so that your pelvic floor can respond to that intra-abdominal pressure increase during those sports.
And so for maintenance, most women can do maintenance on their own, correct? I
Yeah,
mean, once you've kind of learned how to do the exercises, then you can incorporate it. Then you can do it with yoga and Pilates. But you
exactly.
really need that initial kind of training to make it work for you.
Yeah. And like I said, the maintenance is about it can be anything between 3 times a week to 1 time a week. That's what we saw was working. You need to incorporate it in your activities of daily living, either in your sports activity, either before or after your gym exercise. And you need to know that if you stop, because there's going to be relapse, because in life your husband might be sick or your kid, or there might be something. You need to know where to start, and this is something that often women have a maintenance program, but they don't know if they stop it where to start. And so this is in our program what we said to women: if you stop for a while, you need to test your pelvic floor in the lying position. If it goes well, try in the sitting position. If it goes well in the sitting, continue your maintenance exercise in the standing position. So this way you will have the resistance of the gravity, and it's going to be more difficult for you. And the same for the number of repetition and the number of exercise. You need to do certain assessments. So you need to have been taught by your therapist where to pick up and how to test yourself if you're going to stop. And I think this is what is missing. So women, they have a maintenance program and then eventually they relapse. And this is normal, but they don't know where to start again. And because of that, they stop. So I
Um,
think it's important.
I love how brilliantly practical you are. And I can tell that you've talked to so many women and figured out where things get hard, where they fall off, and knowing, okay, you're going to start and this is how you start again, because it just helps everyone continue. When do you think a woman should see a pelvic floor physical therapist for the first time?
This is a good question. I think that around maternity is a very important time. I wish women would be educated about their pelvic floor
Hmm.
earlier than that. There is a study right now from France where they educate in high school younger women about their pelvic floor, because it's important for them to know that if they're going to be doing certain sport, they will affect their pelvic floor
Yeah.
through intra-abdominal pressure. So if that is not possible, I think at least during pregnancy, because there's evidence to show that if you're doing prevention exercise during pregnancy, you can reduce the risk of having incontinence after delivery, and incontinence, prolapse, and different other pelvic floor dysfunction problems. So I would say yes, definitely during pregnancy, you should see a physiotherapist to prevent the problem. So pregnancy is the important time. and the other time is menopause. These are the two times where the pelvic floor function will go down. So if you haven't had any problem around maternity, menopause is really the time for you to at least do prevention so that you don't have the problem when
Yeah.
you're old.
And just to be clear, I mean, you're talking about before pregnancy and menopause, before symptoms, right? Not waiting
Yeah,
until you have symptoms to go. And I think you're right. I mean, other countries do a much better job of educating women about their pelvis. I mean, the UK does as well. I can't speak to Canada, but in the US, we really do not like to talk about the female pelvis at all.
we're starting to do it in Canada. And I think what you're saying, prevention is really important because the numbers are so high
Yeah.
of the prevalence of incontinence as you get older, and there are things to do and there are evidence. So we should train earlier and we should take care of our pelvic floor.
Yeah. Well, thank you so much. Thank you for spending this time with me. And thank you so much for all of the work that you have done. You know, there aren't many things that I think really change my clinical practice, but your work on group classes has really changed my way of thinking. So thank you so much.
That's a pleasure. Thank you. Thank
Yep.
you for having me.
Thanks for listening. If you want more information about me or my online work, check out my website at www.thewomensbladderdoctor.com.